Thank you, Ivy. My name is Kathleen Benedetti. I'm the nurse educator for Cohen Children's Medical Center, the Pediatric Emergency Department, and the Pediatric and Neonatal Critical Care Transport team. Welcome to the Principles of Neonatal Transport. Today we'll be discussing some objectives. So the goals of this education session are to provide you, the learner, with a review of the scope of practice in transport of the neonatal patient, including the legal and ethical implications. We will discuss the principles of ground transport as they pertain to the neonatal patient and transport team. We will identify the key factors in maintaining safety of the environment during a neonatal transport. We'll describe the principles of patient handoff from the sending team to the receiving team. And finally, we'll highlight the important practices to maintain thermoregulation of the neonatal patient during transport. Our scope of practice as it pertains to transport of the neonatal patient is guided by CANES, or for the Commission on Accreditation of Medical Transport Systems. The American Academy of Pediatrics is a member of this team. Our practices may vary based on the employer or the medical director of your program. But in general, we practice under the New York State laws and guidelines. I'm going to click on this link just to show you how you can refer to the website. This particularly looks at emergency services and local laws and guidelines within the state. So you can do this anytime you have a question regarding what your scope of practice is. And this changes, so it's always good to go to the website to get the most up-to-date information. So regarding scope of practice and legal issues, we've all heard of EMTALA, which is the Emergency Medical Treatment and Active Labor Act. This applies to your patient, for example, who arrives in labor in the emergency department. So a patient who arrives in a community hospital but does not have the capability to care for an infant, a newborn, who requires escalation of care may need to be transferred. However, every hospital is required to at least provide basic care and stabilize the patient. They cannot transfer the patient without doing that. That's called, quote, patient dumping. So this is an anti-patient dumping law with hospitals who participate in Medicare must provide an appropriate medical screening examination by a healthcare provider, such as a physician or a nurse practitioner. So this protects the uninsured, patients with mental health issues, and patients in active labor. HIPAA, we're all familiar with HIPAA. This is the Health Insurance Portability and Accountability Act. This is important because you'll be transferring patients with their medical records. So every effort should be made to keep these records secure and handed over at the transfer of care. And legally, a national minimal standard to protect personal health information is required by all facilities. You must provide written notice of privacy practices to all patients and provide authorization forms for the release of PHI or protected health information. We must ensure that the documents are secure at all times during transfer and that they're handed over appropriately to another medical provider. Transfer is acceptable if the hospital does not have the capacity to perform the medical screening examination where they need additional specialized equipment. So this would be important for the newborn, the extramural birth that occurs, say, in the emergency department, and the patient, the infant that needs to be transferred, including the mom. So other reasons why they may not be able to perform the medical screening examination might be a lack of capacity, a lack of staff, resources, or expertise of the physician and the providers. In that case, the referring hospital must coordinate the transfer. Copies of medical records, notes, diagnostics should all be sent over if possible right away. But this is no reason to delay the transfer for paperwork. There's always an alternative option, such as a fax or a courier, that can transport the documents if the patient requires care and they need to move quickly. The referring physician is ultimately responsible for the scope of the medical screening examination, stabilizing the emergency medical condition that they identify, and identifying the appropriate level of transport. So that's where you folks come into play. You are the qualified personnel, and you have the transportation equipment for the infant who needs to be transferred to a higher level of care. And the level of training of the staff should be consistent with the needs of the patient.
In this case, it would be for a NICU patient. So our leaders in pediatric critical care are in agreement with this statement. Appropriate medical care for the pediatric patient with an urgent or emerging condition should never be withheld or delayed because of problems obtaining consent. So consent is usually pretty straightforward. You would, on your transfer consent form, the reason for transfer should be clearly written. The medical benefits and risks should be presented to the patient or the caregiver. The mode and level of transport is identified on this document. The care that's to be provided during the transport, the name of the receiving facility, and the authorized accepting physician. These are all essential as part of your consent. So other things to consider when you're faced with transporting a patient who does not have a parent or legal guardian available at the time of transfer, what can you do about that? Sometimes we go by implied or emergent consent during a life-saving situation. So if the parent's not available because either she is in the OR, she is not awake to sign consent, and there's no one else available, in that case, you may need like an administrator on duty to sign the consent for transfer, and just consider some other options. Is someone standing in for the parent? Is there a healthcare surrogate? So think about informed consent, especially for the infants who are going to be transferred, and find out what your policy is at your facility. So transport services need written policies and guidelines. We conform to federal and state laws regarding consent for the treatment of minors. If possible, we always make every effort to notify the parent if they're not available. So every effort is made to call them, to contact them, to let them know what's going on with their child if they're not present with the child. So consent form, you can refer to the handout that will be provided to you to look at our example of our consent form. So we'll get to the principles of ground transport. And here is our ambulance that we use here at Cohen's. Who is on your team? So you want to think about your team composition. So on our team, we adjust it for the patient needs. So basically, we can send an RN only, but with our ambulances, we always have a paramedic available on the ambulance as well, and an EMT. We can send a combination of a physician, a respiratory therapist, nurse practitioner, RN, any one of those combinations. Sometimes everyone goes, depending how sick the infant is. So think about who's going to be on your team, what their roles will be, and it's usually good to kind of iron those details out before going on a transport. The principles of ground transport, vehicle safety. Your ambulance provider or EMS carrier goes under the U.S. Department of Transportation rules. So you want to know how many passengers can they carry? Are there restraints available to the providers? Is it acceptable under their rules and regulations that you can become unrestrained to tend to the patient? This is often necessary on a transport, but you can discuss with them when that's appropriate. Do they have space for the parent or guardian to travel with them? And if so, is somebody available to talk to the parent? You know, it may be the driver, but someone who can answer the parent's questions. They should have clear guidelines for minimal safe weather conditions. And they should have policies that dictate the safe conduct of transport based on the medical needs of the patient, but also combining the safety of the team members and the patient. And this is one of the most important factors for your patient is safety with transport. So you just want to make sure you're familiar with your EMS provider safety practices. Principles of transport regarding transport physiology. So this is very important when we talk about air transport, which we do here at Cohen's. A helicopter. So we always want to know what's our level of elevation because it will affect the patient and yourself. However, the physical gas laws and cabin altitude does not apply on ground transport. You'll be dealing with gravitational forces. So gravitational forces are probably the most important principles of pathophysiology when you talk about transporting a patient on an ambulance. So what is gravitational force? So G-force is a measurement of the type of force per unit mass that causes a perception in weight. When the G-force is produced by the surface of the object being pushed by the surface of another object, the reaction for this push produces an equal and opposite reaction or weight for every unit of object's mass. So our tolerance of this depends on the magnitude of the G-force, the length of time it's applied, the direction it acts, the location of the application, and the posture of your body. So to consider the position of yourself in the vehicle. Typically, a rear-facing seat may provide better restraint during a crash deceleration. So think about where you're sitting in the ambulance. Where is it safe for you? You need to be restrained. And we'll talk about restraining the patient or the infant as well. So these are some stressors that can occur on transport on an ambulance, but these are stressors for you and also your patient. So consider your tolerance of change in, humidity, the G-forces that will affect you if there's a crash or an incident, fatigue, exhaust and fumes. Can you tolerate that? Is your patient protected from that? Also consider when you're assessing your patient, you may have to rely on some other factors. So there's noise and vibration, so you may not be able to listen to their lung sounds or heart sounds. You may not be able to count respiratory rate. So you really are relying on like your end tidal CO2, your oxygen saturation. You're relying heavily on your monitor as opposed to your other assessment skills. Preparation. So you may have already put together, we're going to just go through what we have here at Cohen's. So this is an example of our transport medication box, and I'll show you a list of some potential things you want to keep in your box. These are our NICU transport bags for neonatal transport. We have a separate one for pediatric transport. We keep an inventory list attached to the bag for a quick reference tool, and you can see that one on the right-hand side. We laminate that. It's a nice quick reference so that if you're looking for something specific, like I need a specimen trap, okay, I see that that's in the front pocket, and it's clearly labeled where the front pocket is. Makes things easy when you're in a hurry. These are links to our documents for what we have of an inventory, and I'll share those with you in a separate document that you can look at. So medications, this is just an example of what could be in a medication box for transport. We do carry a good amount of the medications listed here. Again, you have to consider what type of patient you're transporting, what you're most going to see. So some of these may not apply to your transport, but we do carry these medications, especially for pediatric transport. And then equipment list, consider some things to bring with you. Again, depends on the type of patient you're transporting, but obviously you're going to have an isolette for a patient less than 5 kilos, the capability of providing CPAP to the infant with a ventilator. You're going to have equipment on that carrier for the monitor, so an appropriate blood pressure cuff size, the ability to do a pulse ox and end tidal CO2. You may want to bring a portable transilluminator with you. You want to have Heimlich valves or chest tube equipment available to you. A portable glucometer, very important for your neonatal transports. And the ability to obviously monitor the temperature of your patient with appropriate probes and devices. And then airway equipment. Even though your patients might just be going on CPAP, you always want to have your backup airway equipment available, such as oropharyngeal airway, nasopharyngeal airway, ET tube sizes that are appropriate for your patients that you're transporting. And portable suction is always important. You might be using the portable suction on your ambulance, or you might carry your own, so consider what you want to use. Other things to consider for equipment would be an air oxygen blender capable of delivering an FiO2 of 0.21 to 1.0 with a flow meter that goes up to 15 liters per minute. You want to make sure you have infusion pumps that can run as low as 0.1 milliliters an hour to a high of 1,000 milliliters per hour capability. We carry that because we have pediatric patients as well as neonates, but obviously you guys would be dealing with a much lower infusion rate. Then you might want to have some backup devices for IV access and IO access if need be. We on our transport bags, but you may want a battery-powered one. However, in infants and neonates, we tend to use the manual for anyone less than 6 months of age. You also want to have the ability to have a defibrillator with pacemaking capability with you on transport and appropriate size pads. Some type of drug reference, whether it be electronic on your phone or at least a neonatal drug reference book, is important to have. And then we put chest tube water seal drainage systems here, but that may be more applicable to the people. Before leaving with your patient, very important to make sure you have a secure airway and backup airway equipment with you. That's your priority, is your airway and breathing. IV access, making sure your patient has IV access if they require it, and that you have the ability to establish IV access if they need more en route. It's always ideal to have these two things secure and ready before traveling. Once you're traveling, it's very hard to obtain IV access or secure the airway. You may want to drop and label medications that you might need prior to leaving. For example, a baby who's seizing, you might want to have your seizure medications pre-drawn up and labeled so that you're not fumbling trying to draw those up on transport. And you also have a second nurse at the facility before you leave to double check your medications and co-sign those. Always have a contingency plan if the patient becomes unstable during transport. One of our neonatologists here usually does a quick brief before we leave with any patient on a transport and kind of highlights, why are we transporting the patient? What's their main diagnosis? What are the potential things that could go wrong on transport? And what we will do, how we will address them in case that happens. So oftentimes you have to think about adjusting. You may need to have the ambulance pull over to the side to intubate and stabilize the patient. You may need to have them pull over to the side to establish more IV access or administer medications. You always want to secure potential projectiles on the ambulance prior to leaving, especially medical gases, suction, extra equipment on the ventilator, extra supplies, and make sure that you position team members appropriately to access the patient in their role. So typically we'll have respiratory or the physician sit on the end where the ventilator access is. We'll have the nurse sit in the middle who has closest access to the patient, and she can see he or she can see the monitor. And then the paramedic that goes with us typically sits at the head for airway management if need be. So think about how you want to arrange your team members. Other things to consider, you should have an appropriate strap or securement device for your neonate traveling in the isolette. We have one here that I can send you as an example, but you want to make sure that you follow the manufacturer's guidelines of how to secure that infant properly with that securement device in your isolette. Never add extra equipment inside the isolette to travel with the infant. Always think about everything becoming a projectile. If you hit a bump, whatever you put, maybe you put extra couple of syringes in there or extra blankets on the side. Those things could then hit the patient. So make sure everything is secured. And then how is your isolette going to be locked in the ambulance? That's something you really want to practice with your ambulance provider to make sure that everyone's aware of how they identify that the isolette is secured and locked. You hear a clicking sound typically, so you want to make sure that happens. This is an example, a picture of our isolette here at Cohen. And these are the monitors that we have. So you can see the ventilator is on the left-hand side. We have our temperature monitor in the middle, our servo. And on the right-hand side is our cardiopulmonary monitor with telemetry, pulse ox. And these should always be visible to the provider and the nurse who's transporting the patient. On our carriers, we have our IV monitors, our pumps on one side of the carrier because that's the only place to put them. We also have a neonatal flight carrier that uses different pumps. I don't have a picture of that to show you, but they sit on forward facing. So what you want to consider is where are your pumps going to be, and I have access to them prior to leaving, but once they're loaded on the ambulance, it's not so easy to have access to these pumps. So just consider that when locating your pumps on your isolette. You may want to have these all preset, obviously, before you leave, and then keep in mind you won't have easy access to them once you do leave. So other things to consider when meeting with your EMS provider, orient yourself to the ambulance before transport. It's really best to practice loading and unloading the carrier, practice hooking up the equipment and medical gases on the ambulance before you have a patient in the isolette. Things to consider are the minimal medical equipment required for your transport. What is the oxygen and air capabilities of your ambulance, and how much time do you have on their tanks? You want to talk about the volume of their tanks. Do they have suction available to you? Do they have a backup monitor if your monitor fails? Oftentimes these isolettes they all run on a battery, And if they're plugged in, that's great. But what if you lose power on the ambulance? Do you have enough battery power to get you through your transport? So know your times on your pumps, your times on your batteries, and your oxygen capability. Know where you're going to put your supply bags. Are there cabinets to store these in? Again, they can become projectiles. So you want to make sure you have a safe, secure place to secure your equipment. Where are all the electrical outlets, the power inverters, and the demand inverters on your ambulance? Where's your cabin lighting if you're going to travel at night? Think about climate control within the ambulance. And how are you going to communicate when you're on the ambulance? Obviously, EMS has the two-way radio, but what are you going to use? Are you going to use a cell phone? Are you going to use a personal phone? Think about how you're going to communicate. And then how long can you go before needing to refuel? This may not be an issue. It sounds like you guys have a short transport, but sometimes on our transports, we have to consider, are we going to have to stop and refuel to continue the transport? And then that will affect the length of time you have on your equipment. So communication and awareness for safety. The ambulance company, their driver, if it's going to be an EMT, or they have a hands-free device to communicate. That's important for your safety and the safety of the transport in general. Do they use lights and sirens? What's their policy? Is it appropriate? We've often found research has shown lights and sirens can sometimes put us all at increased risk for a crash. So it may not be necessary or appropriate for this type of transport. Make sure all your stretchers, isolettes can be properly restrained and locked in. Consider emergency evacuation procedures during a crash or a fire on board. This should be discussed with your EMS provider. What are their policies and practices? Do all your team members meet the physical requirements of lifting and carrying the isolette? Do they have the agility to work in a tight area? And what are your team communication techniques? We use team steps here, SBAR, or use something similar. So make sure that everyone is on board with the same communication techniques. Safety of environment and preparedness. Make sure you prepare yourself and your team for working outside of your regular environment. So oftentimes we don't like to think about it, but if you're doing a transport, say, and it's 25 degrees outside at night, and in the event that the ambulance has to pull over due to a breakdown or an accident or something unforeseen, are you as the provider equipped to stand on the side of the road and make sure you have layers on, you have appropriate footwear for weather? Clogs are typically not appropriate for transport. Other things to consider are if you want protective eyewear, you shouldn't really wear anything that's loose, like clothing or jewelry that might get caught on equipment as you're loading and unloading a carrier. Do your team members think about, do they get motion sickness on a transport? Sometimes it's very disorienting to be sitting on the back of an ambulance and not have any windows to look out. So you may not realize that you get motion sick till you're actually in that situation. So consider that. And just being prepared for all different types of unexpected exposures. Another thing to consider is make sure you have important phone numbers, either in the communication device that you're going to use. For example, we use our cell phones here. We often have medical control, EMS dispatch, our respiratory therapist, our A&M, all on a quick one-push button speed dial on our phone. So you want to make a list of important phone numbers that you can take with you so that you can communicate quickly and efficiently. So medical responsibility and medical and handoff of the patient. Many people can have the medical responsibility for a single patient at one time. So once a team is dispatched, there's a duty to complete the response. The other side, the team that's awaiting your arrival, depends on you. Circumstances, conditions are constantly changing. So you want to make sure you communicate these changes if you're going to be later than the time that you're expected to arrive, so that the other team can either rearrange and arrange another transport if they need to elevate the level of the patient's care, give them enough time to contact another provider. Things happen, they understand, but communication. They have to know what's going on and why you're not there within the expected time. So when does duty to the patient start? We have an overlapping responsibility, right? So if you're the team picking up the patient, the sending team is responsible for the patient at the same time that you're responsible for the patient when you arrive. And really, everyone remains responsible for the patient until they leave that primary facility, and then you become the primary providers. So there should be a transfer certificate that's signed by the sending physician at the time of transfer. You don't want them to sign it an hour ahead of time. So have them sign it right before you leave. And the transfer physician does have a right to cancel the transfer at any time, depending on what they think the patient needs. So we always have to keep that in mind. Oftentimes we're called out to a facility and the patient situation may change. Another team may have been dispatched to pick up the patient faster because they were a critical patient. So we have to take that into consideration as well. They have the right to do that. Documentation. So think about the elements that should be included in your documentation tool. Right now, we're documenting on paper for our transports. However, they are looking into some electronic versions. But what do you want to have on your documentation list? So you can put check boxes. These are acceptable for things such as verification of contacts, completion of routine tasks, religion, gender, and then have a written and legible narrative entry area for conversations, orders, observations, interventions, and rechecks. Times, signatures. It should be clear if I read the document what team member performed what function. So did respiratory adjust the ventilator or the physician adjust the ventilator settings? The nurse obviously recorded the vital signs and the patient assessment. What treatment was done on transport? Preparation, maybe a checkbox for that, for safety measures, the care that was provided on transport, and there should be a section for the condition on arrival and any change in condition on transport so that that's very clear. There should be an area to write a quick wrap-up narrative, and I'll give you an example of our document. I'll send that to you separately so you can look and see how we do it. This gives us an opportunity to write details of changes at the arriving facility, write down the name of who the patient was delivered to and report was given to who, and any issues at the receiving facility. Keep in mind, you do have to maintain these records for the statute of limitations duration. So this can be up to 20 years. If you think about an infant, in general, it ends at age 18 for minors, and then add 2 years to file a suit. So 20 years, we should be keeping these records on file somehow. So we have them on paper and they're scanned into a system here. You may be using an electronic version of documentation. So think about, consider that. Outbound information sheet, I'll send you an example of what our transportation communication sheets look like at Cohen's. For orders, I'll send you the example of our transport record as well. As I said, we're working on an electronic version, but currently we're on paper. And then finally, we're going to talk about practices to maintain thermoregulation. As NICU nurses, you're aware of the importance of maintaining your patient's temperature, and this factor becomes even more important during transport. Rapid heat loss occurs in preterm infants. They have a relatively large body surface area, and they don't have the ability to provide enough heat. So heat is lost by conduction, convection, radiation, and evaporation. And these are all important factors when exposing the patient to a new environment. Ambient temperature should be selected to maintain the anterior abdominal skin temperature from 36.5 degrees to 37 degrees Celsius. Abdominal temperatures are used to set the servo controlling temperatures in the isolette or the incubator. So become familiar with your equipment. Preterm infants, which is what you're dealing with, hypothermia is associated with increased mortality, intraventricular hemorrhage, pulmonary insufficiency, and hemorrhage. It also contributes to metabolic disorders such as hypoglycemia and acidosis. Again, patient temp between 36.5 and 37.4 Celsius is your goal. Your patients are being exposed, even though they're in an isolette, when you roll them out from the facility to the ambulance. If they're exposed to direct sunlight, you really should use a cover to protect their eyes and maintain the temperature within the isolette. So you can use a fancy incubator cover. We tend to use blankets or sheets here. They're just easier to work with. Consider seasonal changes, geographic factors, and this can increase the metabolic rate of your patient, O2 demand and consumption. So maintaining a nice normal temperature within the isolette is really important. Recommendations for training. We recommend that your team can prepare for a neonatal transport. Some of the critical elements here. So do a simulation with your EMS contracted provider with the isolette. maybe have an infant mannequin in the isolette as well, just to do a practice dry run. Orient your team to the ambulance. Make sure you're familiar with all equipment, set up the medical gases, plug equipment into outlets, practice that loading and unloading. Make checklists for your equipment, medications, your documents, and your safety checks. And then maintain competencies for staff. I have an example here that I know I can't show you, but I will send you an example of what we do for competencies. We basically have a competency for each piece of equipment on transport that every nurse fills out for the year. So these are the references that I use. This is a really great book, The Guidelines for Air and Ground Transport of Neonatal and Pediatric Patients. If you don't already have that, I recommend purchasing it for your team. It's a great resource. And of course, NRP is our go-to for neonatal care. My information, my contact information is here. Please feel free to reach out to me by email or phone if you have any questions regarding the presentation or any questions in general. We want to help you as you take off on this new endeavor for neonatal transport. Thank you for your time. Have a great day.